So next we have a very popular session that we've had each year. We call it the fireside chat without the fire. And so I'd like to welcome our two physicians that are going to be taking your questions. We have Dr. Harikrishna Tandri from Johns Hopkins, who is the co-director of the ARVC program there. And welcome back to Dr. Mike Ackerman, a genetic cardiologist from Mayo Clinic. Thank you for being here and addressing all the questions of our attendees today again.
Good morning, Marcia. Great to be here. Dr. Tandri, good morning.
Hi, Mike. Thank you. Thank you, Marcia, for having me. It's nice to be back again after the last year's talk.
Exactly. And Mike, you're going to check the Whova platform for the questions. You're good there, right?
I am good. I have Whova up and activated, and we'll get started with them. And if any others come in, I'll keep an eye on them for both Harikrishna and myself. But before we get started, I just wanted to thank Michaela. I've never met you, Michaela. I wish I had. I loved your story, your presentation. Thank you for who you are, everything you're doing. I just loved your presentation. So thanks a lot, Michaela.
I want to second that. Quite an amazing speech. Fantastic, quite moving too. Thank you for thank you for giving all the details and really encouraging the whole folks about how to deal with their conditions. Thank you.
And I appreciate all you both do. Mike, I feel like we know each other. Our names have crossed so many times, but nice to see you somewhat face to face.
Maybe Hari and I can wear that crown someday.
It's all yours. I'll hold you to it.
Well, let's get started, Hari. There's some really good ones, and I'm gonna start the one and pose it to you about research related to diet and impacting ARVC, and maybe I'll touch on whether there's any impact of diet on the channelopathies. But any work done in that area? This question received the most votes, so people must be interested in what they're eating.
I don't think there's particularly specific research that's been conducted on specific diets and ARVC. I think there's, as you all know, there's a long-standing belief that there's fatty infiltration of the right ventricle in ARVC, and somehow it is related to fatty acid metabolism. But that hasn't really translated to actually intake of fat or any sort of fat metabolism by the digestive system to enable increased fat deposition or in that regards. It's all been focused on how the myocardium metabolizes free fatty acids. And there's been a lot of research done trying to look at the molecular signaling pathways that actually deal with lipogenesis and lipolysis in the myocardium. And there are several theories on how fat deposition happens, but I don't think we really have connected that back to the diet yet.
Yeah, and I think just to repeat what we had talked briefly about yesterday was there's really nothing about a particular diet, Mediterranean, Atkins, Weight Watchers, Nutrisystem, that would be QT aggravating. The only caution I would raise is those rapid weight loss programs where you could have changes in electrolytes that could be QT agitating. And then, of course, great caution with consumption of highly caffeinated energy drinks. I think high doses of caffeine in Monster, Red Bull, 5-Hour Energy, so forth, are not necessarily QT friendly and could potentially be QT dangerous. And then, as Arthur Wilde pointed out from research from Sammy Viskin, grapefruit juice, and it's a particular grapefruit juice, it turns out it's purple grapefruit juice, has a chemical neurogenin in it that is a hERG blocker. So, and that could be QT aggravating. Here's the second one, Hari, about is it possible to change the genetic expression of long QT through significant lifestyle changes? Is this being researched? So let's expand that to, is there anything that our patients can do in terms of lifestyle that can change the expression of ARVC? Because there We certainly know about lifestyle changes in terms of don't do endurance training activities. Do you want to expand on that particularly, or any other lifestyle modifications?
So this is a very interesting question. I think we have this mental picture of people with ARVC being high-level athletes, and that is to a good extent. There is a close connection between the amount of athletic activity that one performs in the early adulthood, probably the adolescence and in the early 20s, and the expression or the amount of structural disease that manifests in ARVC. So there seems to be a strong connection between athletic activity and structural progression of ARVC. So this interaction between the genetics and the behavior is what we've tried to investigate in mouse model of this disease. And it is clear that when you exercise mice with an ARVC type of mutation, there is increased deposition of fibrotic material in the right ventricle, and also this increased incidence of arrhythmia. So it does make sense that there is a surge of catecholamines that happens during exercise. If you maintain that in a very periodic fashion for longer periods of time, it does result in increased expression of the disease phenotype. But it is really not a one-to-one relationship. So we do see some degree of variability in the same presentation in the same family and in the same mutation across families as well. So although it is not a direct relationship, that's one thing that is a strong pointer towards increased athletic activity and ARVC. So one lifestyle change would be not to participate in endurance level athletic activity. If you know you have a mutation, it may be prudent not to participate, at least in the formative years, where usually in the adolescence or in the early 20s, don't participate and wait and see how things are progressing. I think you're much more safer once you start once you go past your 20s and into your 30s, you're much more safer to do that. And by default, by the time you get to 50 and 60, your level of athletic activity starts to decline anyway. I'm just talking about all of us, but I'm just saying that there's a nature's way of trying to reduce the amount of catecholaminergic toxicity in your heart or generally in your system as you start getting older. But I think looks like the early formative years are the most important years as far as changing in lifestyle for ARVC.
And I think if we talk about ways to change genetic expression in long QT, is we can't really have us do anything to change whether the gene is expressed more or less. So at that level, I would say there's nothing that we can do lifestyle wise, but there are some, I would say anti-torsatogenic maneuvers that people have been exploring. What I mean by that is making it less likely for the long QT heart to go out of control. And there is in the realm of psychology, if you will, there's been some fascinating, as Hari and I know of, studies showing patients with atrial fibrillation, something completely different, that when they do things like yoga and other things, that their atrial arrhythmia episodes are less. And there's been some data in long QT, it's kind of old now or older, suggesting that your I guess, psychiatric wiring, if you will, the person who's kind of Hakuna Matata, no worries, mate, trouble-free philosophy, remember Lion King, they may be more protected or more resistant to long QT triggered events than the person who's sort of the nervous Nelly, where everything freaks them out, jazzes them. And so people have discussed and explored breathing centeredness strategies and ways to just kind of, as my kids used to tell me, chillax, dad, to just kind of get that. And I think that's going to be an exciting area actually to explore of, are there ways that, yes, we have the long QT substrate, yes, we have the ARVC substrate, but can we help make ourselves more resistant to that substrate going into a danger rhythm by some of these, centeredness countermeasures. And have you seen anything specifically with that, Hari, in ARVC, arrhythmia formation or resistance like we've been reading about in AFib? It's kind of interesting, I think.
I think, Mike, I think you've really brought up a very, very important question. It is a mind strategy that really works well in ARVC as well. As we are realizing now, it's a two-way street, that heart arrhythmias cause anxiety, and that triggers a reaction in the heart. Basically, the moment you realize that you're having PVCs, it focuses your attention onto the heart, and that makes the PVCs happen. And it is very clear that a very calm personality, a person who can somehow control his anxiety towards his arrhythmias, is much more capable of, reducing arrhythmias in the long run than somebody who's jumpy, who basically reacts and very reactive. And we see that a lot in people who are very reactive and who are very anxious about everything. They do end up having more and more arrhythmias, and becomes a self-fulfilling prophecy. It's almost like they tell me that I told you so. Everything this happens, that happens. But I keep telling them it happens because you make it happen. It's almost like when you start focusing and when you get anxious, the heart starts to race and you start having more PVCs, and that creates more anxiety. So I think I'm a very big proponent of any sort of mind control. I think not only in ARVC, I think it probably helps in most cardiovascular conditions to reduce the impact of the disease itself. And one other topic, I think, as you rightly pointed out about AFib, what we are coming to understand is sleep is a very important component of both structural and arrhythmic progression, especially in ARVC. One of the commonest way people trigger this problem is by sleep deprivation and dehydration. Right. So I think paying a lot of attention to your time, the duration and the quality of sleep. It's not, I want to stress not just laying in bed, but the quality of sleep. And especially what Mike just brought up, mind control is very, very important in reducing your overall clinical course.
Yeah, I think there's great opportunity there and great excitement in the sense of if gives us a chance to get the upper hand. And I'll never forget, Hari, where probably now almost 2 decades ago, we had a patient with long QT2 coming in. She was in an electrical storm, and the resident called me, and I told them, has she been given Ativan or Valium? They said no. I said, give it to her stat. It is one of the most powerful antiarrhythmic drugs. And they looked at me as like I had really gone off the deep edge. But it's absolutely true. That drug is probably one of our most powerful anti-rhythmic drugs we have in our arsenal. And a lot of our colleagues and trainees even don't really know that, or have forgotten that, or they just frankly don't believe it, but it's true.
Oh, the first drug of choice. VT Storm is sedation. Yeah. VT Storm is reducing anxiety. It's the first drug of choice for us. And we go the next step of propofol and anesthesia. Even before propofol has no effects on the heart. Basically, that's the first step we do even before we go slam them into lidocaine or amiodaripes and whatnot. So I completely agree with you. It's a very vicious connection between the brain and the heart that makes this refractory.
Well, we have a question from Amy, and I'll start it, but then I'll ask you its role in ARVC. And Amy's asking about left cardiac sympathetic denervation, LCSD. How is it performed and when do we do it? So we at Mayo Clinic, we've done more left cardiac sympathetic denervations than anywhere in the world. And so I think we're in a good position to talk about it. It's a minimally invasive surgery where we go in through the left armpit with 3 very tiny incisions. There's a chain of nerves that runs along the left side of the spine. And at a specific address, we remove that chain en bloc, and we remove it. And when you remove that chain from a certain region, and we call it the lower half of the stellate ganglion down to T2, 3, and including T4, so that's the address, it makes it much harder for the long QT heart and the CPVT heart, and actually almost any heart, to go into a danger rhythm of ventricular fibrillation. So it's called an antifibrillatory procedure. And in a sense, it's essentially a localized ablation or removal of the localized release of noradrenaline, norepinephrine. Its use is really twofold. It started in our program as my disease is bad. I'm having recurrent events, recurrent shocks. Is there anything we can do to get the upper hand to make it less likely for my long QT heart, CPVT heart to go into the danger rhythm? Over time, the second indication has actually become the more common one, which has been my disease isn't that bad, but I hate my treatment. In other words, I'm one of those Ackerman beta blocker zombies where my disease has never done anything, or maybe made me faint once, but now every single day I feel lousy from the beta blocker. And this is where I again remind us, many patients don't mind their beta blockers at all. So I do get a skewed sampling of the motivated patients who've concluded that they do not like life on beta blockers, who then ask, is there a way to get on less beta blocker or potentially no beta blocker? And that answer is yes, there is, left cardiac sympathetic denervation. And so this used to be just the guidelines from Mayo Clinic, but they have now been codified in the American Heart Association, American College of Cardiology guidelines, where both of those indications, bad disease, try to get control, or as a beta blocker alternative in the setting of beta blocker intolerance, are now deemed class 1 clinical indications, meaning it's agreed by the cardiac societies that it is a bona fide clinical procedure with the demonstrated efficacy. I'm going to pitch it to you now, Hari, because we have started to do it in not a large number of ARVC patients, but basically in our program, any patient from any substrate where we've gotten the impression that adrenaline has been the proximate trigger, exertion events, etc., that they are potentially a candidate for left cardiac sympathetic denervation. And I'm curious what your experience has been with doing denervation therapy in ARVC.
I think this is a very good question. It kind of ties very well with what we just talked about before. Just for the viewers, it is through these nerves the brain communicates with the heart. So brain and the heart are hardwired with each other. And it is through these ganglia that brain can exert its influence on the heart. So when you get anxious, when your heart rate goes up, it is because of firing of these nerves, which makes it happen. So by disconnecting these nerves, you're basically doing, I'm not saying exactly, but what meditation would do for you is by removing the influence of the brain on the heart. So we have started a structural program where we actually do it not in specifically in long QT. We have a whole big population of patients with ARVC and sarcoidosis and other cardiomyopathies. And we've started doing sympathetic denervation in people who fail catheter ablation and or patients who are intolerant to antiarrhythmic drug therapy and still get recurrence of arrhythmia. And we've had excellent results in this patient population. When I say excellent, it's not like they're completely devoid of arrhythmia. I would say about half, about 50% of them are free of arrhythmia at about like 3 or 4 years of follow-up, which is stellar compared to, because they were having arrhythmias despite catheter ablation and amiodarone. And the remainder have occasional ICD therapies compared to having recurrent storms before. So it's a substantial improvement from where they were by doing this sympathetic denervation. We generally tend to do both sides, not just the left, which is usually done for long QT syndrome. We do left and the right because there's some data suggesting that there is control both from the right and the left side. And it's basically a situation very similar to like a transplanted heart, which has no nerves when it goes from one person to the other, but still has the vagus. The brakes of the heart are still intact in a sympathectomized heart. So I think it's a very good therapy for patients with refractory arrhythmias, may it be CPVT or ARVC. We've had great success in sarcoidosis and also some very difficult arrhythmias such as Lamin. Again, it has to be looked at from case-by-case basis to see which of the patients will benefit. And surely if there are indicators that exercise or adrenaline has been an important part of the arrhythmogenesis, I think clearly those patients tend to benefit a lot.
Let's focus, since denervation is not really a new therapy, but a application of an old therapy to your disease, ARVC, and ours. Let's look at from Leah what's around the corner in terms of novel therapies for ARVC. But her specific question, and I'll start with it, is what's the current status of gene suppression therapy or gene therapy? And yesterday, Dr. Greg Webster gave a really nice presentation on gene therapy. The specific type of gene therapy that we've been advancing here is called suppression replacement gene therapy. So that was the second example from Dr. Webster, and we had published that in the journal Circulation in February. We're really excited about this. We will be presenting it next week of suppression replacement gene therapy in the dish for type 2 long QT syndrome at American Heart Association. So we first did it for type 1 long QT syndrome. We have essentially cured the long QT1 and long QT2 patients in the dish, meaning our suppression replacement gene therapy works to bring the cell's QT interval back to normal. And we are cautiously super excited. We have a major hurdle to overcome. So this is just round one, and round one, mission accomplished, success, rah, rah. But the next phase is the pre-human rabbit model. So there are rabbits who are our animal model with LQT1 and LQT2 that we are treating with our gene therapy vector that we've designed. And if it takes the rabbit's long QT and has it go away, has the QT normalized, then that will be a huge hurdle that we've overcome. So I would say we're going to know that answer, whether it worked in the rabbit within the next year. If that answer is yes, then we will be filing an FDA submission for what's called an IND to do the gene therapy in the first LQT1 and LQT2 patients. The exciting thing about our suppression replacement gene therapy is that this strategy could work for any monogenetic heart disease that has what's called a poison peptide effect, where the bad copy bothers the good copy and causes the disease phenomenon, which is a little bit different than some of the ARVC diseases, where the bad copy just causes essentially a 50% reduction of that product. It's not as if it poisons the good product. And so for those kind of genetic heart diseases, we may not need the suppression replacement strategy, which is really suppression replacement. What we call it is out with the old, get rid of everything, and then in with the new, replace it with the good. But there are many genetic heart diseases where that mechanism of poisoning the system is in place, if you will, where out with the old, in with the new is going to, or could potentially be, the strategy of choice. Now, of course, all of the things that Dr. Webster pointed out of, we need to get the cargo, the therapeutic cargo, delivered to all of the heart muscle uniformly. And if we do that sounds like easy, but that's not. That is going to be the so-called Achilles heel, because if we do not achieve that, then this strategy of gene therapy will not work. And so there's a lot to do. We're super excited. There should be an announcement in the very near future of a very significant collaboration to advance this. So I'm excited, but if the rabbits don't cooperate, then it may be back to square one. So it's like Bugs Bunny and those Wasco Wabbits. If they behave, then we'll be even more excited. But let's shift it, Hari, to whether it's gene therapy or not. Is there any novel therapies being explored for ARVC? Because I've always been frustrated with the ARVC patient. Do I or do I not put them on the heart failure drugs? What do I treat them with anyway? What's happening?
So I think that there are several things that are out there that people are testing, especially aldosterone antagonists for prevention of fibrosis, ACE inhibitors. There's a trial going on flecainide, both in terms of reducing calcium-mediated toxicity in these patients, for reducing arrhythmias and somehow even reducing disease progression in the end. And some of these molecules that are being tested again in the Harvard labs, just to see if they will have some effect on genetic models, mice models of ARVC. But I think compared to long QT syndrome, I think we're very far behind in coming up with specific genetic therapies or targeting pathways in ARVC. It is frustrating because most of these are empiric at this point. There is really no strong data supporting or no evidence supporting reduction in long-term outcomes or change in phenotype based on these therapies. And so my practice has always been do no harm. If the patients are having symptoms from any of these drugs, most of them cannot tolerate antihypertensive sort of ACE inhibitor dosing. So in those cases, I tend not to put them on for an unknown benefit because it just makes their life miserable every day. They wake up with lightheadedness or not feeling, not having enough energy. So I always go for comfort. Patients should actually, they should enjoy their life and, be lively and whatever, and work with them on a very individual patient by patient basis. So just to answer your question, there's really no evidence that any of the drugs that we're testing so far has any impact on the expression of the phenotype of the gene or the gene itself.
And then, Hari, on flecainide for ARVC, that's one that has fascinated me. I love that drug. I love it for my CPVT patients. There's certain patients with even long QT3 where flecainide, because of the specific mutation, works great, whereas normally we would use mexiletine. But I had used flecainide very early, probably a decade ago, in one of my ARVC patients. And then that data came out showing that PKP2 may decrease the sodium channel secondarily. And then it made me nervous, thinking that, okay, if the PKP2 mutation causes a downregulation of the sodium current, is this a good thing of me to add flecainide to the mix? And so it spooked me, honestly. And I took the patient off of the flecainide out of concern that I might create a problem. And so is there some new data that's encouraging you to think about that drug? Because for a while, I was really excited about it in ARVC, and then I got super nervous.
Yeah, so the same group, Mario Delmar's group, which actually published on reduced sodium current on using flecainide, later came up with a theory that actually flecainide improves, reduces the arrhythmic recurrence in ARVC based in the cellular models, reduces the calcium transients through from the sarcoplasmic reticulum, thereby reducing delayed after depolarization. So actually, the same group again came up with data supporting the use of flecainide, but our practice really is from seeing patients do really well with flecainide. Yeah. And I have come up with a way that patients can take flecainide. We have patients with flecainide as a pill in the pocket. They take it on days when they're stressed and they feel lots of PVCs, and they use it as a pill in the pocket. There are patients who actually take flecainide only during the day, but not during the night, because the heart rates are usually low during the night and they don't have much PVCs at all in their Zio patch monitoring. You see that it's almost like a Manhattan type of towers during the day, and there's nothing in the night at all. Yeah. So the brain goes to sleep, the heart goes to sleep with it. And only during the day they use flecainide, and they play with their dosing. They take 50 if needed, at 75, whatever it is, whatever that suppresses. So I think instead of coming up with a regimental approach of it has to be 100 BID or 150 BID, they figure out what their dose is and figure out what really works for them. And that seems to, work really well for the ARVC cohort. And based on
really encouraging, I think that's really encouraging for our ARVC, because I love hearing that from you, because I've been wanting to hear a good reason to try using it some more again, because it made good sense to use it until like I said, I got a little bit spooked.
I asked them to give drug holidays, just skip flecainide for a few days and see how you feel. And so basically they get control of, yes, I can manage this all by myself. And that gives a lot of, that empowers them to be very understanding about their condition and what they can actually use and to prevent the symptoms.
Here's one for you, Hari. Do you recommend quinidine in your practice for the young adult 30s, 40s with asymptomatic, never a symptom Brugada, where they really have just the Brugada pattern on ECG, maybe with or without confirmation by genetic testing? But do you empirically put the asymptomatic low-risk people on quinidine?
No. I generally tend not to treat asymptomatic Brugada at all.
Yeah.
The best thing to do is go get the ECGs of the mother and father if you can get a hands on it. And if you find the same pattern in them or in any one of them, I basically reassure the person and say, this is how your part is. And usually if they have had no events and whatnot in the family, I just reassure them and usually not institute any treatment or follow-up. It's only when it comes in with all the paraphernalia that usually comes up with the patients that recurrent syncope or there is something malignant going on in the family, then that this is a question to be had on what is the best course of treatment. But really, we stay away from asymptomatic Brugada patients.
And I completely agree. Turn to myocarditis. And so this is a question of whether myocarditis from the SARS-CoV-2 virus itself or myocarditis that could rarely occur, and just for the audience, occurs way less from the COVID-19 vaccines than from the natural virus infection itself. But myocarditis resulting from either way, can it trigger the ARVC disease to go next level and activate the process, accelerate the process? Have you seen that occurring at all? Because we pleasantly have not seen that concern bear out in HCM, in long QT, and there was a theoretical basis for why long QT people could have more events during the setting of COVID-19, because COVID-19 sort of causes an acquired QT prolongation, like taking a QT drug. But we haven't seen that in long QT and HCM, pleasantly so. What about ARVC from the virus infection itself that causes COVID-19, or from either the Pfizer Moderna vaccinations that has a low rate but a measurable rate of vaccine-associated myocarditis?
Sure. So one has to understand that ARVC in its earlier stages can present like myocarditis. So the patients have come in with clinically looking like myocarditis, hardly indistinguishable from viral myocarditis, and having a lot of arrhythmias during the period of time. And over a period of time, they develop into this ARVC phenotype. So myocarditis in early presentation of ARVC is a fairly common entity. Most of the times it's not diagnosed because most of the viral myocarditis or most of these myocarditis tend to be asymptomatic unless they result in an arrhythmia. I have seen patients with COVID-induced myocarditis, but not the combination of ARVC and COVID-induced myocarditis. So COVID myocarditis resulting in arrhythmias from the right ventricle without having ARVC. They didn't actually have ARVC, but they were referred to me because they've had arrhythmias rising from the right ventricle, and they are young individuals with no other history before. And interestingly, they all had very long viral illness, especially coinciding with the early COVID surge in the United States. And their hearts on MRI looks like both biventricular myocarditis with probably some increased presence of wall motion abnormalities on the right side. And they presented with arrhythmias both from the right and the left ventricles. But they did not have the genetic mutation of ARVC. And they did the appearances on MRI and also the presentation in that way made it unlikely that it was actually the genetic ARVC or the ARVC that develops from extreme exercise or exertion. We have not had a flare-up of ARVC because of either the COVID virus or the COVID virus vaccine. We've had several of our ARVC patients take COVID vaccine and several actually getting COVID as well due to direct exposure, and none of them have had increase in their arrhythmias. They did go through the same illness that most of other folks with their COVID underwent, 2 weeks of viral fatigue and fevers and so on and so forth, but it hasn't actually made a big impact on the ARVC itself. So looks like it's a random occurrence of myocarditis. Yes, you could have a myocarditis if you had an ARVC patient getting COVID, but that's just a sheer coincidence. It would have happened anyway.
That's really encouraging, don't you think? Because I mean, I know there was a concern that if you got myocarditis from whatever mechanism, related to COVID or not related to COVID, that could serve as a disease accelerator in ARVC. And it's just not looking like that's necessarily the case.
Not really. We had several calls from people getting COVID and we're very concerned about how this is going to turn out, both in terms of their structural heart disease and arrhythmias, and really nothing happened. Actually, the good news about ARVC patients is that they're physically extremely fit and super athletes, and they are the best ones who can go through COVID without any problems. Right. So I think that coming in with that sort of goods really helps.
I'll take this next one from Rochelle. It's a great one, as all of the questions have been, but she heard that there's a new drug that she calls a ryanodine receptor antagonist being trialed for RYR1 mutations, which is skeletal muscle ryanodine receptor. She's asking if it's possible that this drug or a similar drug like it could be used in RYR2 patients, in other words, patients with CPVT. Rochelle, you're spot on. Maybe you have an inside track on some work that we and others are doing. But this drug, so the company's name is Armgo Pharma. The drug was discovered, the compound was discovered by a friend and colleague of mine, Dr. Andrew Marks out of Columbia University. The drug is in a class of drugs called the RYCALs, or ryanodine receptor stabilizer. And you're right, this compound, this drug is in clinical trial right now in patients with skeletal muscle myopathies. And the same drug will probably be used in a first in-person CPVT trial that we'll be directing from Mayo Clinic and Arthur Wilde out of the Netherlands in CPVT patients. I would bet we should have it up and running within the next 12 months. And so there's a lot of excitement around this potential drug. It would really be the first drug specifically for CPVT, as opposed to what we currently use, which is beta blockers and flecainide. And by the way, flecainide works great in CPVT. But again, the possibility of having a disease-specific drug developed. If it works, this drug may find uses in a lot of other things where there are leaky ryanodine receptors that are the result of the disease process. And so I think that stay tuned, but clinical enrollment for the drug is probably 6 to 12 months away. Hari, Anna is asking about basically ICD implant related complications. And she's wondering, have you ever seen any patients who've developed a plexopathy or a brachial plexus syndrome or a thoracic outlet syndrome after the ICD implant? Or are there any other conditions to consider when somebody's experiencing arm swelling and finger tingling on the side in which the ICD was implanted a year after the ICD was placed?
So these are well-recognized complications of putting leads inside the subclavian vein, and inflammation is pretty much not the same in every individual. Some people have a very brisk thrombophlebitis after puncturing through the subclavian vein, and the trauma that results in putting these leads in can lead to a brisk reaction in that space, causing progressive narrowing of the vein around the ICD leads. And about 8 months to 1 year is about the time when you start to see reduction in blood flow. And if usually there are very well formed collaterals around it, you may not notice any arm swelling. But if you do lack collateral blood supply around that region, it's not uncommon to develop swelling of the ipsilateral arm or the same side arm, along with some vague sensations just because of increased hydrostatic pressure in the arm. So I think it's rare. I would say that it's very uncommon for us to see that. Generally, in these days, when we only put one lead in the ventricle, the single chamber ICDs, because most of these patients do not require pacing. So it's very rare to see that happening, but it is not completely out of the picture when patients get ICDs.
Great, thanks. Well, it's hard to believe that 47 minutes have passed already in our fireside chat. These have been great, but I'm going to ask both you and me, probably more so me, to do speed dial on our responses so that we can go through the rest, because a lot have come in while we've been chatting together. So we have 15 minutes on the clock, and we'll see if we can make it through all of them. Does the QT interval always have to be prolonged for torsades to occur? Answer: no, not always, but most of the time. If your QTC is really, really normal, your risk of torsades is really low. Hari, how important is genetic testing for first-degree relatives for patients with ARVC?
Well, if there's a known mutation that's found, it is probably very relevant for the first-degree relatives to be screened with ARVC. Blanket screening, just without even knowing the proband mutation, probably is not recommended. I think that's what I would say. It's like if there's a very well-documented mutation in the proband, I would recommend screening the first-degree relatives.
Great. And this one I'm glad you get, because I have to confess I don't know the answer. So Alan's asking, is there any impact to ARVC patients with hemochromatosis?
Any impact of ARVC and hemochromatosis? I don't specifically think so. Recurrent blood transfusions that recurrent blood letting in hemochromatosis may cause some degree of right-sided pressure changes, but I don't really think there's a direct connection between hemochromatosis and ARVC.
Yeah. Does it make a difference if Sotalol is taken with or without food? Alan's asking and says, it seems like he gets both suggestions all the time and conflicting recommendations on how to take Sotalol, or what's the best way to take Sotalol.
I would just say best way to take Sotalol is to take it with food. I would just generally recommend that for most patients. But again, whatever suits you, whatever suits your, I think in the end, I think Sotalol gets into the system and basically does its job. So it's basically whatever suits you, what needs to be done in the end. But I would say take it with food.
Yeah. And this is ARVC and transplant. And Patrice has several questions in here, and basically, as ICDs and drugs continue to improve, are more ARVD patients going to live long enough to need heart transplants? How what percentage of ARVD patients get transplanted today? And do you see that trend changing?
I think the fundamental thing one has to remember is that ARVC is not a continuous progression where everybody is going to progress in one direction. It is the people who present very early in their life, in the teenage years, with severe right ventricular disease. These are the people who we keep a close eye on because they already are starting off with a very less reserve, and they're going into their adulthood with very impaired right ventricular function or some degree of LV dysfunction. These are the people who we keep a close eye on to see at what point they would need a heart transplant. But most ARVC people do perfectly fine with a little bit of lifestyle changes and control of arrhythmias. They basically cannot carry on almost all activities without any limitations and really don't progress over long periods of time. We've had about 15 years of follow-up in many of these people right now, having started in 2000. Now we have at least a good cohort of people that we're following, and most people are doing great without any change in the ventricular function. And the people who did progress actually presented way early in their life with multiple mutations and also severe ventricular disease.
Yeah. I'm curious how many of your ARVC patients have been transplanted to date? Because for us, it's been three total. And those have, like you just said, they've all been children with very early and impressive expressivity that by the time they were, 13, 14, 15, we sort of waved the white flag of surrender on that heart and went the transplant route.
Right. So we have over about 1,000 people, 1,000 families in our database right now in the last 20 years. And I would say on our watch, about 13 people got transplanted so far. Yeah. So that's pretty good news. Yeah. And I would have been able to identify all these 13 people right on day one, just because of the way they presented and the way they were picked up. So it is quite encouraging. And most people do absolutely fine with ARVC.
Great. Jasmine's asking, what kind of patients with long QT syndrome benefit from mexiletine? Mexiletine has been great in LQT3. We've also published recently its use in LQT2 patients, especially those with a QTC above 500, where you're getting tempted to use a defibrillator. If the addition of mexiletine drops their QTC below 500 milliseconds, we'll stand down and not install a defibrillator. So the use of mexiletine in LQT2 has been very helpful to reduce the number of ICDs. Ruth is asking that an ARVC patient probably had a myocarditis or a hot phase after the second shot of Pfizer or Moderna. So would you recommend for that person the third shot? If so, do you think this would be the kind of person where you would just say, let's shift to the non-mRNA one and give the Johnson & Johnson as the booster? What would you do in that scenario?
I think it's a clearly, again, I would say it's a mind game. If you think that next dose of vaccine is going to probably result in myocarditis, I think it's probably a very bad choice for you to go for a next vaccine, because it's almost, it will put you into a state of panic as soon as you take the vaccine. I think as long as you can come to terms and completely talk about this in a very rational way and take yourself out of your body and look at it very objectively, that's a different thing. That's exactly what I would have suggested. Go for Johnson & Johnson. But if you are a type of person who would say that, boy, this is definitely going to make things worse, it will be a very rocky course, both in terms of psychological impact that it will have on that particular patient.
Yeah. Rochelle has another great question about the ryanodine receptor and its role in insulin release and glucose and beta cells. And I think, Rochelle, the answer is there's not much more to talk about than what you just said, except that we are learning that the ryanodine receptor that we thought at one time was only in the heart muscle actually resides in the beta islet cells of the pancreas. resides in the brain. That's where we discussed yesterday about developmental delay. And so these channels have a role in insulin secretion, and so do the LQT1 and LQT2 associated potassium channels. And so there's probably a very subclinical pancreas insulin sugar phenotype. It really doesn't seem to matter clinically. So the influence of these channels, I would say, is a very fine-tuning influence. It's not a major influence. And if that influence is altered, ultimately not that big of a deal. Jenny, thanks. Your compliment, I appreciate the tone of the conference. So thank you for that. And then she just shares her frustration that when our patients participate in a research trial, they're not permitted to see their personal results. And I think there, Jenny, it depends on what kind of research trial are we talking about. If you're participating, for example, in our genetic discovery trial where you don't know your mutation and we're trying to find a new gene, and if we do find a new gene, you do learn about it. So, but when we find nothing, we don't make a habit of telling people we're still finding nothing. If you're talking of a research trial where you enroll with Hari's program or ours in a new drug study, there we're just simply not allowed. We're not permitted by the appropriate conduct of a trial to tell you whether you got placebo or whether you got the active drug, and until that trial is released and published and vetted. And so it's just we're grateful for research participants, but there is a certain, the way the game has to be played in the best interest of all parties. And so I get what you're saying, Jenny, but it's kind of the way it is. And I hope that brief explanation makes sense. Anything you would add to that, Hari?
Yeah, I think sometimes we ourselves are not aware of what the participant has been randomized to or what the participant actually got. And that adds to the scientific rigor of the trial itself and removes the element of bias, which is very important, especially in coming up with the right therapies and not have people's biases influence the end results. So it's the construct of the study itself that limits our ability to disclose information.
Jennifer's asking about her 15-year-old daughter whose genetic test came back with VUSs, and we had a wonderful lecture yesterday from your genetic counselor, Murray, Brittany, and she gave a great talk. But so timely is it came back with a VUS in both RYR2 and KCNH2. Have we seen both variants before? Basically, we've seen everything. So I would just say I would be delighted to help if you needed help in adjudicating which variant that matters. Could both matter? Yes, unlikely. It's likely that one matters more than the other, and it all depends on does your daughter look more like CPVT or more like long QT? And so, but you certainly people can have more than one thing. And here, Christy's asking, can you explain the mechanics of adrenaline causing VT in ARVC patients? So maybe a little bit of a dissection on what's the direct link or what's the cascade from an adrenaline surge in any setting, anxiety, fear, exercise, activating the ARVC heart to go into VT?
So that's a very important question. The way we understand adrenaline is that it's as if somebody injected something into your veins and it's traveling. It's a chemical that travels through the blood and attacks the heart. But what is more important is what's locally secreted from the nerve endings in the heart. So when I talk about an adrenaline surge, it's an instantaneous deposition of adrenaline in the synaptic terminals in the heart, directly on top of the muscle by the millions of nerves that exist, millions of sympathetic nerves that exist in the heart. What it does is it changes the electrical properties of the muscle, making it slicker so it can conduct faster, And it can also, they shortens the refractory period of all this, shortens the ability of the muscle to contract quickly again after one single contraction. So by doing that, it prepares the heart for a fast beat. It prepares the heart to be able to beat really, really fast. And one of the elements that it uses is called cyclic AMP. It's one of the signaling protein. When it does that, it increases the release of calcium in preparation for a muscular contraction. And this calcium is what, as we all know, is also a stimulant for the muscles to fire. So some of these cells start to fire automatically. And if you have scar on the heart, and if there is a circuit, it's able to latch onto that circuit and cause VT, these bursts of PVCs, once they start to coming in regular frequencies with the changed conductive properties of the heart, makes it more likely for you to have sustained VT, but also a disorganization of conduction throughout the heart can also put you into ventricular fibrillation. So it is what happens at a very local level that seems to be very important in adrenergic or catecholinergic mediated arrhythmias.
And I'm going to have Marcia get ready in the bullpen to come on up. But before we do that, we're giving Carl the last question. And so Carl, you get the last question because it's a really good one and I can't pass over this one because I think this is where you and I have work to do, Hari. And he's asking about the 2015 task force for ARVC with the class 2 recommendation, encouraging, I guess, prohibiting competitive sports in those who solely have a positive genetic test result for ARVC, but whose heart is structurally normal, electrically normal after doing every test that you and I know how to do. And he's saying, since ARVC doesn't have 100% penetrance anyway, what's the negative impact? What negative impact might this have on telling these people with a positive genetic test who aren't showing the disease that they can't do any sports? Does the pendulum need to swing back a little bit for what we do or do not let these people with ARVC do?
It's a great question. It's a very touchy topic too. It's a very common question that comes up almost in every conference. I think the pendulum swung way too far. So it's like one size fits all. Let's just stop exercise and everybody play flute. It's not going to work. There are folks in the RVC where you take a detailed history and you realize that they're just doing normal stuff. They're really not high-level athletes. They're not doing competitive sports and they have other hobbies and whatever. We don't really touch them. For the people who are pushing themselves to the limits of trying to train, we basically come up with a plan. They say that we'll watch you more closely. We'll see you maybe in 6 months and we revisit. And as long as things are going well, we'll keep doing what you're doing. If there is a change, then we'll discuss about what should be the next step that we need to do. So I think it is, again, taken on a case-by-case basis. Most importantly, to address this thing about a blanket recommendation of not doing anything is really not going to fly. It makes people take their identity away. People who are avid swimmers and people who are basically athletes and whatever, just because they have a mutation, it doesn't mean that they have to completely change their lifestyle. Again, a very close attention to the family history also helps. If there's another sibling with the same mutation, with the same phenotype getting the disease, that's a different situation. So if none of the high-risk features are there in the family, and if you just have a mutation, it has to be worked on an individual case-by-case basis with more, the pendulum swinging in the opposite direction, letting them do more and closely observing them rather than put the brakes on.
Great. Well, Dr. Tandri, and you mentioned swimming and things, so I'm going to give a shout out. Emmy's mom sent this to me yesterday. So that is Emmy winning the state championship in the 100-meter butterfly. So 100-meter butterfly, and she has type 1 long QT syndrome, the one with the swimming connection. So I think, like we've tried to say, and how Michaela in her presentation earlier said, it's really a new day for our families with genetic heart conditions. Yes, they may predispose to sudden death. That's awful, but that almost never happens when we found you, have diagnosed you, have risk stratified you, and have treated you well, that scary part of the equation almost never happens. And now we spend all of our time, since that's not the goal, meaning preventing sudden death is no longer my goal, because that's pretty easy. It is enabling you to live and thrive despite your condition. And that's what the SADS Foundation under Alice Laura's leadership has been all about, and her team and Marcia putting together this conference. So Dr. Tandri, I want to thank you again. You're a wonderful partner, a great guy. I love doing these with you, and look forward to seeing you on a real conference in person. Because I'm kind of done with these. But no, Marcia, thanks for putting on this virtual one, since this is still the state of the world. But thanks a lot. Thanks for the great questions. I hope you have a wonderful rest of your virtual conference, all of the attendees. And so, Marcia, I'm going to turn it back to you. So thank you so much.
Thank you.
Thank you both, Drs. Tandri and Ackerman. It's been a wonderful